Hello everyone, my name is Yupei Duan, and I am a third-year PhD student in the School of Information Science and Learning Technologies at the University of Missouri. I'll be presenting supplementing patient encounter training for pre-service nurses towards an AI XVR approach. This is a team project, and I would like to introduce all the team members. Dr. Xinhao Xu, an associate professor, my advisor, and the principal investigator of this research project. Dr. Hao He, an assistant professor at Emporia State University. Yuan Gu and Shaman Li, PhD candidates in the same program as I am. And last but not least, John Bruno Vasca, an associate teaching professor at the Pennsylvania State University. This work introduces an immersive VR clinic in which pre-service nurses practice patient encounters with generative AI-driven standardized patients, or AI VSPs. The central framing is supplementation, which means we are not proposing to replace standardized patients, but to evaluate whether an AI XVR approach can provide scalable, on-demand rehearsal that supports readiness for subsequent standardized patient encounters. I will begin with the motivation and the problem context. Firstly, standardized patient encounters provide realism and formative feedback, but remain resource-intensive and difficult to scale consistently. At the same time, immersive VR can standardize exposure while maintaining embodied interaction, and generative AI can enable open-ended, persona-consistent dialogue. Importantly, open-ended dialogue matters because patient interviewing is not only about recalling a checklist, it also involves conversational control, redirection, rapport, and adapting to different patient and communication styles. Therefore, our work investigates an AI XVR approach as a supplement to standardized patient-based preparation. The key design question is whether we can preserve the benefits of authentic conversational practice while reducing barriers to repeated rehearsal prior to a standardized patient encounter assessment. To achieve this objective, we firstly developed an immersive VR clinic, enabling pre-service nurses to practice patient encounters with artificial intelligence-driven virtual standardized patients, while speech-based open-ended conversation. Secondly, the system incorporates varied patient personas and lightweight, transfer-oriented scaffolding with captions and cue sheets as assistants. Specifically, our evaluation focuses on usability, self-efficacy change, transfer to standardized patient encounter performance, and perceived facilitators and barriers. We ground this approach in transfer of training and a deliberate practice, which means that repeated criteria-aligned rehearsal can improve readiness and generalization to a subsequent assessment context. The platform is a Unity-based VR clinic deployed on MedQuest 2 with push-to-talk speech interaction. Learners speak through the headset microphone and press the button on the controller to speak, with an on-screen indicator confirming when the microphone is active. The conversational pipeline is automatic speech recognition, plus large language model-based dialogue, plus text-to-speech integrated while inward, supporting spoken interaction with an embodied avatar. We added transfer-oriented support, live captions for verification and repair, and a floored cue sheet listing core history-taking props. The caption displays both learner and patient utterances, which supports conversational repair when recognition errors and supports learners' metacognitive monitoring. As shown here, three AI virtual standardized patient personas, introverted, ambiverted, and extroverted, were authored to elicit adaptation to patient communication style. The instructional goal is to encourage learners to adjust the pacing, prompting, and conversational management depending on how talkative where reserved the patient is. At the same time, personas share an identical clinical case profile, which is acute low back pain relating to the right ankle, isolating persona effects from the diagnostic content. In other words, the learner experiences variability in conversational dynamics without confounding the underlying clinical information target. A floating selection menu allows learners to choose which patient persona to interview in each encounter. We used mixed methods, quasi-experimental design. AI virtual standardized patient practice was offered as an optional preparatory activity. In practice, this means learners who opted in AI virtual standardized patient encounter practice formed the experimental group, and those who did not opt in formed the comparison group using long-standing course preparation materials. The practice dose was roughly 30 minutes AI virtual standardized patient encounter session across 3 personas for the experimental group. Sessions were recorded so the headset video and audio functions. For quantitative assessment, both groups completed an standardized patient encounter within 48 hours, and performance was scored using a shared 15-item rubric with 2 independent raters. Additionally, we measured usability using the system usability scale, self-efficacy using the motivated strategies for learning questionnaire, self-efficacy subscale pre and post AI virtual standardized patient encounter session, and post-session engagement, presence, and immersion on 5-point Likert items. Quantitatively, we conducted semi-structured interviews and analyzed transcripts using Brown and Clark's thematic analysis to identify facilitators and the barriers that contextualize the quantitative results. Let's see our findings. First, usability was high, with system usability scale was equal to 81.6 out of 100, consistent with excellent usability. This suggests the system is operable enough to support routine practice without excessive interface burden. Second, self-efficacy increased following a single AI virtual standardized patient encounter session. Third, standardized patient encounter performance did not differ between AI virtual standardized patient users and controls. Fourth, AI virtual standardized patient encounter performance was not associated with engagement, presence, or immersion, although experience measures were intercorrelated. From the results, we can see that the learners generally felt engaged and present, but that affective experience did not directly predict rubric coverage in the AI virtual standardized patient encounter. The interviews help explain why. We identified 3 overarching themes reflected on the slide. The first theme is engaging learning. Participants reported engagement and a sense of presence attributed to the headset-based clinic and open-ended dialogue. The second theme is educational benefits. Participants described improved redirection, elicitation of sparse information, and question sequencing consistent with increased confidence. The third theme is usability challenges. Some participants reported friction points that increased workload, particularly latency or phrases, synthetic voice quality, and limited turn-taking control, including overlong responses and weak interruptibility. Based on our study, we propose some concrete design priorities, such as constrain agent responses to approximately 1 to 3 sentences, enable reliable bargain interruptibility, and reduce automatic speech recognition and text-to-speech latency while improving prosody. The quantitative data indicate that conversational controllability is central to educational utility because It governs pacing, cognitive load, and the learner's ability to steer the encounter. In addition, we recommend maintaining a single user clinic with minimal interface overhead and using concise rubric-aligned scaffolds, captions, and cue sheets to support coverage without scripting. The broader implication is that in AI XVR training, usability and dialogue mechanics may be as important as graphical realism. Curriculum integration implications. We recommend positioning AI virtual standardized patient encounter sessions as low stakes, on-demand warm-ups prior to standardized patient encounters, and distributing multiple short macro sections across a module. This supports repeated practice while limiting fatigue and providing opportunities for targeted rehearsal. Our conclusions are, first, an AI virtual standardized patient clinic can function as a usable and confidence-building supplement to standardized patient encounter preparation. Second, observed outcomes indicate increased self-efficacy with performance parity relative to traditional preparation, supporting a supplemental rather than replacement role, particularly after a single brief session. Third, interaction mechanics, latency, robustity, and interruptibility emerge as primary determinants of educational utility and perceived realism. Finally, we note that this study reflects a single course context and an optional participation design. So future work should examine long-term use, multi-site development, and designs that reduce self-selection effects. Thank you for your attention. I welcome your questions.